want to
great.
just show you guys or explain to you guys maybe what a session looks like for me, intake or follow-up. I can talk about both. So for an adult versus kids for intake, it's a little bit different and it's different from what you guys do. So for an adult, typically our intakes are going to be in person. And if the intake's not in person, we definitely want to see them in person in one of their first few follow-ups because we need their vitals and we need to put eyes on them and things like that. So adults, they get one intake session, preferably in person so that we can get their vitals. Children, they're going to get 2 intake sessions. The first one's going to be online and it's going to be with the parent to gather collateral information, hear the parent's concerns separate from the kids' concerns. And then the second one is going to be in person with the parent and the kid. Depending on the kid's age or the kid's preference, sometimes I'll take them back alone to start with so they feel validated and heard by me first instead of just feeling like their parents in the room staring at them or interjecting. And so if I take them back, I'm going to do vitals and I'm going to explain to them why I'm doing vitals. So I always introduce myself to people as, hi, I'm Val, I'm a PMHMP here, or a psychiatric nurse practitioner. And then I'll ask if they're familiar with the role of a nurse practitioner. I find today, normally most people are familiar of what my scope of practice is, but some individuals hear nurse and they think nurse. Nurse practitioners, if someone says, no, I'm not familiar with that, I just give them a quick little education of like, I'm able to assess, diagnose, and prescribe medications for you today. And that is why I would need to take your vitals, because sometimes when we take medications, those medications can alter your vitals. So getting a good baseline set prior to starting medications can be beneficial to notice even the minor changes in you. I feel if people don't think about medication wise, they're like, why is this psych person taking my blood pressure? Like, what does that matter? So I always kind of explain to them that the medication management is why I'm getting their weight, their height, their blood pressure, their pulse. We get the weight and height, especially on kiddos, because they're growing, right? And some medications can suppress their appetites and change their growth rate. So those are important things for us to monitor, as well as blood pressure and heart rate. Some medications we prescribe, whether they be stimulants or SNRIs, can increase your blood pressure. Some medications that are anti-anxiety medications can decrease them. So we really want to make sure if we're on agents that are affecting our blood pressure or pulse, that we have a baseline, and that every so often we're checking it and or checking it at titration. So that's when we're going to go up or down on it. Some of these medications, if you take a beta blocker every single day for a year, and then your body gets used to that, a beta blocker slightly lowers your blood pressure and is a rate control agent. So manages how quickly or regularly your heart is beating. Things like propranolol. If you're taking that every single day for a year and then you just decide, meh, I don't want it anymore, your body is acclimated to having that medication. And so you can get something called rebound hypertension, which means your body thought it was supposed to get its daily dose of propranolol. So it had acclimated to that. And now, because you're not having that medication, it goes through the roof. Typically with rebound hypertension, it goes away after a little bit, but those are just things that we want to monitor, especially with patients that sometimes our populations, they are medication non-compliant, right? They take their medications, they go, oh, I'm fixed, I feel great, I don't need this anymore, and they check it behind them. So just being able to have those baseline vitals is important. As well as then I kind of sit them down, and before I even meet them, I go through all of their intake paperwork, similarly to what you guys do. They have to fill out what, 11, 12, 13 forms. So I look at those and I look at the scales, the same scales that you guys are looking at and gathering every so often, as well as I look at an additional piece called the medical history form. So that one is just saying like allergies, who their primary care provider is, family health history. So not even just them, but parents, grandparents, family, just because with some medications, primarily stimulants. If a family has cardiovascular history, like, oh, their two uncles had heart attacks at the age of 30, that's when we're going to want to get cardiology involved, get a baseline EKG, and get a write-off that their heart is healthy enough to start these medications, right? Because yes, psychiatric care is important, but also your physical health is important as well. So it's this nice balance of risk benefit. So after kind of doing that, I will then sit them down and then I tell them, I looked through your paperwork, but we can only type so much. We can only get our message through so much online. I would love to hear in a brief sentence, like, what led you here to medication management today? Some people do give me a nice brief sentence. Some people go, it all started back in 1990. And then sometimes I have to reel them back in a little bit. But so I want to hear their chief complaint, what led them here today, as well as I want to get a good idea on them. And that means their age, their gender, where do they work, what's their educational status, if they're in school, do they have a 504 IEP, what's their preferred name, preferred pronouns, things like that. And I write it in bold and I copy and paste that over so that every note I have, I just get that nice little blurb about them in my notes. And then I'll gather allergies. So medication allergies and food allergies. I just like to note both of those. And I like to keep it kind of high up on my list. And then I'll kind of go into past medical history. So what have you been diagnosed with in the past? Does that mean that I'm going to also say, yes, you have all of these things? No, I might disagree, but I like to have a baseline of what they've heard, what their knowledge is of possibly their current condition and things like that, as well as the history of presenting illness. So what do your symptoms look like? Is it every day? Is it a certain time of day? What does it feel like physically? How long have you been experiencing that? Things like that. Sometimes the patients are able to kind of just tell me the HPI all on their own. Sometimes I do need to kind of go down the DSM list if I'm assessing and just ask them questions, right? And then I will gather some also important information like history of suicide attempts, history of suicidal gestures, history of self-harm. History of behavioral higher levels of care, whether it be inpatient, IOP, PHP. It's good to know, have you had that level of care and when you had it? How, an individual that is just coming to me fresh from PHP is a lot different than, oh, I had PHP 2 years ago. And then history of therapy treatment and if they're currently in therapy and if they're in therapy here. So I like to write down all of the therapy that they've tried, right? So I want to know if they are an on-off, like, oh, I go for 6 months and then I stop and then I go. I like to ask, like, do you know what type of therapy? Was it CBT? Was it exposures? Was it talk therapy? And if they have had different types of therapy, I like to kind of hear, oh, I felt like this worked or I felt like this didn't. So I'll write a little blurb about that. And then history of behavioral health medication trials. So what medications have you tried before? And what were the dosages? How long were you on it? And why are you no longer on it? I specifically like to ask how long you were on it to see if it was an adequate trial, especially with like children and ADHD. If you took the medication for 2 days, 3 years ago, that wasn't an adequate trial. It doesn't mean that that's a bad medication for you and maybe we could revisit it. So that's always an important thing we like to gather, as well as behavioral health family history. So has mom been diagnosed with anything? Dad? Has anyone in the family committed or attempted suicide? Things like that, as well as I always like to fit in there if you feel comfortable sharing. So if mom says, I have anxiety, I'll ask if you feel comfortable sharing. Sometimes individuals with genetic links can respond in like ways to medication. So if you're on sertraline and you responded very well, typically if your child needs an SSRI, I would start with the medication you responded well to, or sometimes they'll have a sibling that has gone through PHP IOP and is on a medication. So I always like to say, if you're comfortable, I never want to make someone feel like this provider is not my provider and now they're asking me what medications I'm on. But typically, most individuals feel comfortable sharing that, and they will share that information with me, which I find very helpful because it kind of just gives, is that medication going to be the right medication? We don't know, but it gives a little bit of like a direction for us to go in, as well as if the patient has ever had behavioral health testing. I like to have them, if they didn't get it at Light on Anxiety, I love to have them send it in, and I love to see when it was done, how long ago it was done, and what actually did they assess for, because they can all be like a little bit different from place to place. So I really like to have that physical copy, not just, oh yeah, and we were diagnosed with this. And so that is kind of the question portion. And then I'll go into more like medical health, and some medical health matters to me just because I talked a little bit about it. Our medications can impact things like seizures, cardiovascular health, blood pressure. So I like to ask, have you ever had an abnormal EKG? Have you had any, or the child, cardiac conditions, the family history of early cardiac or unexpected cardiac death, seizures? That's a really important one. A lot of our medications can lower the seizure threshold. So seizures is one that I always make sure to ask. Head trauma as well. And then asthma, as some of our medications are contraindicated with asthma. So those are the physical health things I like to assess for. And then I will kind of go into educational mode and kind of talk about like the current clinical picture, what the standard, like gold standard for what I have assessed for. So if I say, if I'm assessing that your daughter has anxiety, generalized anxiety, it's moderate at this point, that indicates CBT with an SSRI, and then talk to them a little bit about what that looks like, how the SSRI can benefit them, side effects, risks, the black box warning. It's a lot of information all at once, but I multiple times throughout will kind of ask, do you have any questions? As well as asking about current medications. Are they taking anything by mouth daily? Everything matters to me, whether it's melatonin or it's medication for their lupus. So I will ask about both over-the-counters, vitamin supplements I like to know about. There are a couple that really do not mix well with SSRIs. And then the previously tried psychotropic medications I also will kind of write down here. And then we kind of talk about the education. There's a good 15 minutes of parents asking quite a bit of questions, because starting a child on medications that's a big thing for a lot of parents, especially when they're younger. And then kind of talking that through. And then I typically will at intake sessions for adults, I'll possibly start medications because they're in person and I have a great clinical picture. But for the kiddos, because I haven't seen them at the intake session, then we'll schedule that second one in person. I'll let that parent kind of marinate with that clinical recommendation I gave them. So if they want to go to Dr. Google, which they always will, always will, at least now they can come to me prepared with questions with a little notebook. Instead of just emailing me 12 questions, if I don't even recommend that at the primary intake, and then I first recommend it at the in-person intake. And so that's kind of how the session goes. And then, if I'm ordering medications, I'll kind of instruct them, are you taking it with food? What time of day? You do need to be taking this every single day, or I'll explain how to take a PRN as needed, and how to notice when it's indicated and how often you can take it safely, and then order the medications and reschedule them. I always like to reschedule them in the same visit, just so that I make sure they don't get lost in the cracks. And that's my whole intake.